Thank you very much, Chairman. Before I begin, let me thank Professor Assad and the organizing committee once again for the kind invitation. It is really my great pleasure to be in this beautiful country. So in this talk, I'm going to discuss with you the role of lens extraction in primary angle closure glaucoma. These are my financial disclosures. In fact, there are several roles for lens extraction in angle closure glaucoma. First of all, in the acute disease, it can serve to abort the acute attack. After the acute disease, it can prevent a progression to the chronic form of the disease, and also it has a role in the management of established primary angle closure glaucoma. In my talk earlier this morning, I discussed the first two roles, and so for this particular talk, I'll focus on the third, the management of established primary angle closure glaucoma. The general principles in the management of primary angle closure glaucoma, in my mind, involves three steps. First, you try to open up appositionally closed portions of the angle as far as possible. If the intraocular pressure is still uncontrolled, then you start topical medications. And if the intraocular pressure is not controlled by maximally tolerated medications, then you proceed to further surgery. But how do you open up appositionally closed portions of the angle? I think there are three major steps that you can use. First of all, in the majority of cases, there is an extent of pupillary block, and so you can consider starting with laser peripheral iridotomy to eliminate the pupillary block. If there are still residual appositionally closed portions of the angle after peripheral iridotomy, then you can consider argon laser peripheral iridoplasty, which I've discussed a bit this morning, as well as also in my talk at 8 o'clock tomorrow morning. And finally, I will have a relatively lower threshold for lens extraction in such patients if the pressure remains uncontrolled even after the iridoplasty. But of course, if all these does not work, then you have to consider medications, and finally, you will have to consider further surgery, especially filtration surgery. These are some of the surgical options in primary angle closure glaucoma. They include trabeculectomy, cataract or lens extraction, goniosiniculisis, deep sclerectomy in some parts of the world, and perhaps in Japan, trabeculotomy even in adults, glaucoma drainage device implantation, and also diode laser transscleral cyclophotocoagulation. Or, of course, you can also do a combination of the above. In this diagram here, I try to summarize, maybe I shouldn't say summarize, but try to give you an overview of the various surgical options and when to do what. If you are faced with PACG, first you try to eliminate appositional closure. If there is adequate intraocular pressure afterwards, then of course you are very happy, patient is happy. But otherwise, you have to proceed down here. If there is extensive PAS, short duration of closure, and also the glaucoma is not too advanced, then you may consider goniosiniculisis with or without lens extraction. Otherwise, you proceed down here when you consider lens extraction, trabeculectomy, or a combination of the two. And it is mainly around this arm of this diagram that I will focus my attention on within the next 15 minutes or so. If intraocular pressure is still uncontrolled after multiple trabeculectomy attempts, then you may consider either glaucoma drainage device implantation in cases with good visual prognosis, or cyclodestruction in cases with relatively poorer visual prognosis. I think the clinical scenarios in PACG can be largely grouped into these subcategories. They either are coexisting with cataract or without cataract. And in each category, you can either be controlled with drugs or not controlled with drugs. Now, let's first look at the situation when it coexists with cataract. As we all know, PACG increases with age. Therefore, the majority of PACG is coexisting with cataract. And now there's also increasing evidence that the cataract may also contribute to the pathogenesis of PACG. We are now fully aware that by removing the cataract, you substantially deepen the anterior chamber as well as widen the drainage angle. Furthermore, some case series has also demonstrated to us that by removing the cataract, you reduce intraocular pressure as well. So in the group of cases with coexisting cataract, traditionally the treatment is to perform combined phacotrabeculectomy, which deals with both diseases at the same time. But in view of the above evidence, we were just hypothesizing that whether just by taking out the cataract alone, it would be sufficient to treat both diseases at the same time. So we were wondering whether phaco is sufficient to replace phacotrabeculectomy altogether. Now, first look at the situation when the intraocular pressure is controlled with drugs, and what should we do? Should we do cataract extraction or should we do combined surgery? This graph best summarizes the results from a randomized controlled trial that we performed in Hong Kong on PACG patients that are medically controlled and with cataract. And we randomized these patients into receiving either cataract extraction or combined phacotrabeculectomy. In the interest of time, I'll just forget the green line for the time being, but focus on the red and the blue line. The red line are those cases treated by phacotrabeculectomy. You can see that there is quite a good reduction in intraocular pressure, which is sustained over the first 24 months. There's also reduction in intraocular pressure in those patients treated by cataract extraction alone, but to a lesser extent. But in terms of drug reduction, both treatments resulted in significant reduction in glaucoma drug requirements, and this is largely sustained over 24 months. But phacotrabeculectomy does have a significant advantage in this aspect. So if you look at the numbers, cataract extraction alone reduced intraocular pressure by almost 10% and drug reduction by almost 60%. If you do the combined surgery, there's an additional 1.67 millimeters mercury of IOP advantage, and also you reduce the drug requirements by a further 0.8. But then, we'll come back to the complications later. Now, let's look at those cases that are medically uncontrolled with drugs. Should we be doing phacoemulsification or combined surgery? We do the same more or less the same randomized control trial in this particular group of cases that are medically uncontrolled but with coexisting cataract, and we randomize them into phaco or combined surgery. And here, this graph demonstrates very clearly that with either surgery, you can reduce intraocular pressure very significantly, and this pressure reduction persists for at least the first 24 months. If you look at the drug requirement, once again, a very similar picture emerges. Both treatments are useful, but then phacotrabeculectomy has a definite advantage over just removing the cataract. Once again, looking at the numbers, if you look at cataract extraction alone, there is almost a 1/3 intraocular pressure reduction and more than 50% of drug reduction. But if you do combined surgery, there's a further 2 millimeters mercury of IOP reduction over 24 months and a further 1.25 reduction in the number of drugs required over the first 24 months. So, combined surgery has better IOP reduction and also greater drug reduction than phacoemulsification alone. But what is the price to pay for this advantage? Let's first look at the complications. For the phacoemulsification group, about 8.1% of the cases had a total of 5 surgical complications, whereas for the phacotrabeculectomy group, about 1/4 of the cases had a total of 19 surgical complications. If you look at additional surgery required, in the phacoemulsification group, about 6.5% of them required subsequent trabeculectomy within the first 24 months after surgery, while in the combined surgery group, 18% of the cases required additional procedures to maintain filtration. So, in terms of complications and interventions, phacoemulsification may have an advantage over combined surgery. So I think at this juncture, with the results available, I would at this point conclude that in cases with PACG and coexisting cataract, doing trabeculectomy alone has probably a limited role for the reason that these cases already have visually significant cataract, and we know that the cataract is involved in the pathogenesis of PACG. Furthermore, after trabeculectomy alone, we are well aware that the cataract will progress. If the situation is medically controlled, then I think probably the benefits of combined surgery is not sufficient to justify the risk of complications and the additional interventions. And so in this situation, you might consider doing cataract extraction alone. Whereas if the cases are medically uncontrolled to start with, the greater benefits of combined surgery may or may not justify the risk of complications and additional interventions. And in this situation, either approach may be adopted, depending on patient factors. You may consider phacoemulsification alone if, for example, the patient is more prone to the risk of trabeculectomy complications, if the eye may not tolerate or may not survive the greater trauma of combined surgery, or if the patient cannot accept a higher risk of complications. On the contrary, you may consider combined surgery if, for example, the patient has a very known poor compliance with drugs, the patient has known drug allergy, or the patient has no long-term access to drugs or to clinical follow-up. Now, let's move down these categories. In those patients with PACG with no cataract, if the intraocular pressure is controlled with drugs, then probably I'll be inclined towards continuing the drugs. But what if the intraocular pressure is uncontrolled with drugs? Traditionally, in this situation, when there is no cataract, medically uncontrolled PACG, the treatment would have been trabeculectomy. But with the available evidence, once again, I would hypothesize whether doing phacoemulsification alone, now this time this is clear lens extraction, would that be sufficient to replace trabeculectomy altogether? We proceeded to a randomized controlled trial comparing clear lens extraction versus trabeculectomy in this particular group of patients, and we defined uncontrolled IOP as having an IOP of greater than 21 millimeters mercury with maximally tolerated medications or requiring more than 3 topical drugs to maintain intraocular pressure of below 21. At this juncture, I should try to clarify the difference between our study and that of the EAGLE study, which has recently been discussed a lot. Basically, both studies are randomized controlled interventional trial, but we have slightly different target patients. In the EAGLE study, they were targeting newly diagnosed PACG eyes before peripheral iridotomy, and these eyes have no cataract, whereas we were targeting uncontrolled PACG eyes with prior peripheral iridotomy but no cataract. And then the interventions involved in the two trials are also different. In the EAGLE study, they were comparing clear lens extraction versus peripheral iridotomy, whereas we were comparing phacoemulsification, clear lens extraction versus trabeculectomy. So if you look at the intraocular pressure profile over the first 24 months, both treatments, phacoemulsification and trabeculectomy, are effective in reducing intraocular pressure. Both treatments are effective in reducing requirement for glaucoma drugs, but once again, filtration surgery has an edge over phacoemulsification, at least over the first 24 months. Phacoemulsification reduced intraocular pressure by about 34% at 24 months compared to 36% by trabeculectomy. Phacoemulsification reduced the requirement for glaucoma drugs by almost 60% as compared to almost 90% by trabeculectomy. In terms of complications, 3.8% of the eyes in the clear lens extraction group had sonnular dehiscence with capsular tension ring implanted, whereas in the trabeculectomy group, almost 46% of the eyes had a total of 13 complications. Now, at this point, I must stress that amongst this 46%, actually one-third of the eyes, 33% of the eyes, had developed cataract over the first 24 months after surgery. Otherwise, these cases have their fair share of other filtration surgical complications. If you look at subsequent surgery, in the phacoemulsification group, about 1 in 5 of these eyes were indicated for trabeculectomy within the following 24 months, whereas for the trabeculectomy group, 1/4 of the cases required a total of 10 additional surgical interventions during the first 24 months after surgery. So I think at this point, I would say that phacoemulsification, clear lens extraction, is effective in improving intraocular pressure and the requirement for glaucoma drugs at 24 months after surgery. Clear lens extraction has a low rate of complications. You can avoid the potential complications of trabeculectomy by doing clear lens extraction, but after clear lens extraction, the dependence on glaucoma drugs remains significant. In comparison, trabeculectomy allows you greater reduction in drug dependency, but it is associated with more surgical complications. So I would conclude that phacoemulsification may be an appropriate alternative to trabeculectomy as an initial surgical option in medically uncontrolled CACG eyes without cataract. Phacoemulsification may be more favorable in patients who are prone to or cannot accept the complications of trabeculectomy, while in situations where drug reduction is a high priority, trabeculectomy may be more suitable. Of course, in our study, we didn't address the role of phacotrabeculectomy in this group of patients. When you consider phacotrabeculectomy in this group of patients, you have to bear in mind these key facts. After clear lens extraction, 1 in 5 of the cases were indicated for trabeculectomy during the first 24 months after surgery. And after trabeculectomy alone, 1/3 of the cases developed cataract within the first 2 years. Now, with this final slide, I try to summarize the role of lens extraction in various situations of PACG. When it is medically controlled PACG combined with cataract, I would be inclined towards performing cataract extraction. When it is medically uncontrolled PACG with cataract, I will be doing either phaco or combined surgery depending on patient factors. If it is medically controlled PACG with cataract, then I would consider continuing the drugs. If it is uncontrolled PACG without cataract, then I will be doing either clear lens extraction or trabeculectomy depending on patient factors. The last bit here is what I presented this morning, is the role of lens extraction in acute primary angle closure. It is possible to perform lens extraction to abort an acute attack of angle closure, but it is generally not recommended because of the high surgical risk associated with doing this in a hot, inflamed eye. But I think there's a good role for lens extraction in preventing a progression to the chronic form of the disease after an acute attack of primary angle closure. The critical question here is when to perform this procedure. In theory, the earlier you perform the procedure, the more effective it is to prevent development of PAS. But the later you perform the procedure, the lower is the risk of surgical complications. At present, we believe that the best compromise is probably to perform the lens extraction at about 1 month after the initial acute attack of angle closure. So if you're interested to read a little bit more about the role of lens extraction in ACG, here are some of our publications in recent years. Thank you very much for your kind attention. Thank you once again.